Teenagers. Now, what do happens to the teenagers, like after 7,
Depending on whether they have a family history or not.
about how diabetic and how eye health is related?
So, diabetes, as we all know, is because of increase in blood sugar in our blood.
Different lenses has come up, or what kind of surgery has come up. People are still scared.
Cataracts and cataract surgery has come a long way.
What is ROP?
So, ROP, retinopathy of prematurity, it is a condition that we see in babies that are born prematurely.
Hi, welcome to Inspire from Reality. As promised, every time we bring a guest who has a journey, the journey can be journey of advantage, journey of wins, a journey of failures. Everything together makes a human being, and that's what they do. They lick their wounds in the dark and they pat their back alone. But when there is a crowd and when they have to get up, they get up and work towards the success. They build the empire around them. So today as a guest, normally I don't read this, but today as a guest, I want to do the justice by reading her correct bio to you. She's a wonderful person and I have been excellent fan of her. Today we are joined by someone truly special, Dr. Swati Ninadkar, Adelaide-based ophthalmologist who spent more than 15 years helping people of all ages see the world more clearly. She is not only known for her clinical expertise, but for her incredible warm and reassuring approach to the care. Dr. Swati is trained in Royal Australian and New Zealand College of Ophthalmologists, and since completing her specialist qualification in 2015, she has a reputation for being thorough, gentle, and wonderfully patient focused. For children with squint to adults with major cataract, she prides herself in clearly listening, explaining things, and simply tailoring the treatment to each person's need. Her patient often describes her as more than a doctor. They call her a trusted partner on their eye health journey. As if you ever visit her clinic, you will know why. Dr. Swati, you will never just another appointment. You are cared for the family. Dr. Swati, we are very excited to have you here today.
Thank you so much for the kind words. Thank you. It's lovely to be on your podcast. And thank you for inviting me.
Swati, we always start with the first dialogue. Your past is what is your present. Somebody's past might be struggle, somebody's past might be pamper, somebody's past might be education, somebody's past might be lost. But let's discuss today, how was your past? Where were you born? How did you decide to be a doctor? And why did you come to Australia, and your journey, please?
Well, I was born in Mumbai, the busiest city in India. And I've got an older sister and a younger brother. So it was a family of 5, and we've been brought up in a middle class family, and all of us gave a lot of importance to education. So we were very supported by our parents to sort of learn and get the highest education that we can. So my sister is a PhD, and my brother, he's a dentist. So we all come from medical backgrounds, and we really valued our education quite a lot. Then I got married to Ninad, who's a chartered accountant by profession and has been my pillar of support all throughout my journey in India as well as in Australia. We migrated to Australia in 2008, and since then I started my struggle with getting Australian qualifications. It took me 5 years to 5 years of tears and pain and everything to get through the college requirements and then take the exam. And finally, I was a fellow of Royal Australian and New Zealand College of Ophthalmologists. And as I said, Ninad has been a pillar of strength throughout my journey. He has been very supportive. I've been very lucky to have him, as well as his parents, who looked after our, then 4-month-old Advik, who I had to leave in Adelaide and travel to Darwin to sort of complete the requirements of the college. So it's been a challenging time of my life. Also, once I finished the college requirements, I did my fellowship in pediatric ophthalmologist, which was in Perth for 1 year. That's pediatric ophthalmology is something that's very close to my heart, and I'm very passionate about vision in kids, because most of the vision loss in kids is reversible, and if treated on time, we can actually give them a better life. So I'm very, very passionate about that part. So I did the fellowship, and then I started working in Adelaide again. So that's my journey and life in short.
But tell me, were you already a doctor in India?
I was a trained ophthalmologist in India. So I finished my ophthalmology training, and then we decided we'll migrate to Australia. So Ninad came here to do his MBA, and that's how I joined him, and then we started our journey in Australia.
Yeah, this has been a thing that I've been always hearing, that when you come over here, and I like that about Australia, and I also sometimes dislike because for a doctor, they give so much of importance because you are having somebody's health in your hand.
Yes.
But you have to qualify over here again, re-qualify over here again when you are such an established doctor.
Yes.
That's great, and sometimes it's very frustrating for a doctor like you, like who has to spend again 5 years to re-qualify, right?
Yes. Well, initially it was frustrating, but I'm very lucky, I would say. I had a lot of people who supported me in that journey, and they did help me sort of achieve my goal. I mean, retrospectively, looking at my journey, I think people have, most of us who have migrated have gone through a similar pattern. And I think it is an important part when everybody's coming from different backgrounds, to set a standard curriculum or a standard practice guideline, and everybody to be aware of it. I think it's a good thing, but yes, at the time it did not feel like it.
Obviously, with a child, I can understand. I can just imagine. But really, congratulations. That's been a big journey. I was going through all your work and everything, and I'm really so proud to say that you have come up such a big journey from 2015 to now, and all your clients or patients' testimonial is amazing.
Thank you. Thanks. It's not just me. It's a teamwork. Teamwork makes good dream work. I've got a good team. I've always had good support, and I think that's what made the difference.
So let's talk about, since we started with pediatric and about kid, so what is the things that kids, when do they see eye specialist like you, and when do they, because you can go to maybe to OPSM or Specsaver normally, but still people delay a lot to start the kids journey. And then when is the time when they refer to you, and what are the things that you help the kids with? As you said, it's to reverse the eyesight losses. Little easier, not, I won't say always easier, but it's little better.
I think the earlier the presentation, the better it is to treat the problem. I think the first step should be getting screened by an optometrist at around preschool age, so around age of 4, because that's a good time where the child has already started to communicate a bit, and we can get the level of vision. And if there is a problem, we have enough time to sort of treat it or do something. Most common cause of reduced vision in kids is needing for glasses, or having need for glasses, having long-sightedness or short-sightedness. So if it's picked up early, then we can reverse something called as amblyopia, which means that the eye, the vision in one of the eyes gets weaker, or the eye gets lazy. What it means is the connection of the eye to the brain, which sort of helps with the vision development, is quite immature in younger kids up to the age of 7. And if we don't pick that up earlier, before the age of 7, we can't fix it after. So we need to be able to pick that up really early in their life, so we can then start the treatment, prescribe them glasses, and do other treatments to treat amblyopia. So then once we do that, then for the rest of their life, they won't have a problem with amblyopia. So that's something that we really look for when we see a child.
Oh, wow. That's such an important, like picking up early and before 7 is so important. Like that's a big takeaway from this particular thing, that for child, whenever something happens to a child, we all feel so sad for them. But early detection, early going to a doctor is very important. With
Absolutely.
teenagers now, what do happens to the teenagers like after 7? I won't say they're teenager, but they do behave like a teenager after 7 these days. But let's talk from that 7 to 20, that age.
Depending on whether they have a family history or not, the older the kids are, the chances of short-sightedness is more. Now, short-sightedness is growing like really rampantly, especially in metropolitan cities where there is less outdoor time spent and more indoor time, more digital exposure. So short-sightedness has become extremely common in older kids, not so much in younger ones, but very common in older ones. And there are some treatments available to slow down the progression of myopia or short-sightedness. And the treatment can involve using special myopia control glasses or using drops in your eyes every day for a few years, which sort of slows down the progression. But the bottom line and the main lifestyle change that we need to do with these kind of kids is to reduce or increase their outdoor time. They need to, so if there is a strong family history of short-sightedness or the child is already short-sighted, then we should encourage them to spend more time outdoors, at least 2 hours every day.
That's
So that's the
interesting.
standard guideline.
Yeah, that's interesting. That we all know. It's a very basic thing, but we all know. Hardly we implement.
Very too busy.
Yeah. So since we're talking about lifestyle issues, another one is high blood pressure. So how does it also affect your eye vision?
It can. So blood pressure can affect your eyes in multiple ways depending on what level of blood pressure you have. So if you have really, really high blood pressure and it's say undiagnosed, sometimes it can cause significant swelling of the nerve, which is quite severe. But on an average patient with blood pressure who's sort of moderately controlled, they can have we call it a mini stroke. So one of the blood vessels can get blocked in the retina, and that part of that retina may not receive any blood supply, and that can produce again abnormal blood vessels or cause swelling of the macula. We can control that swelling by again those injections that I was talking about, but prevention is the best cure, and keeping the blood pressure optimum can avoid you from having these problems and then the treatments which have to be continued forever.
After 20, it's all about lifestyle. And I was going through a little bit of what you have done, work, and I was looking into your website and all. So there is a very important talk that I saw was about diabetic. And as our lifestyle is changing a lot, younger generations like in 30s are getting diabetic more. So and I know that there's some relationship between diabetic and eyes, but we are not educated or informed enough mostly. So I would like you to talk to my audience about how diabetic and how eye health is related, whether the eye loss with diabetes is reversible or not.
So diabetes, as we all know, is because of increase in blood sugar in our blood. And that happens due to various reasons, unhealthy eating, lifestyle changes, stress, family history, and all those things. So I think what it does to the eye, what diabetes does to the whole body is basically weakens the blood vessels in our body, and then the blood vessels start leaking protein and other substances out of the blood vessel wall, and that causes swelling, especially in the eyes, and also causes some changes in the retina, which is the inner layer or the back layer of our eye. In early stages, so there are different stages of we call it diabetic retinopathy, which means that the retina is damaged because of diabetes. There's something called as diabetic maculopathy, which means that the center of our retina is affected because of diabetes, and that is swollen, and we need to treat it. In some cases where the where the changes are very early, some of them can be reversible, and the diabetic maculopathy can be controlled with control of your blood sugar levels. But in advanced cases, you cannot reverse the changes. However, with well-controlled diabetic levels or sugar levels, you can maintain the changes that have already happened and not let them go worse. There are different reasons why you can lose vision because of diabetes, and the most common one is having a swelling at the macula, which is diabetic maculopathy. There are some injections available that we actually give inside the eye. They call intravitreal injections, which can reduce the swelling, but the injections have to be done quite every few weeks, and there is no end point to those injections. So it could be something that they would be having for many years. Definitely helping controlling the risk factors, like controlling your sugars, controlling your blood pressure, your cholesterol, and other vascular risk factors helps in overall control of your eye disease. But definitely there are treatments available for some of them. Now, this end-stage diabetic retinopathy, unfortunately, has no treatment. And once the retina has started to produce new blood vessels or abnormal blood vessels, we do need to do some laser treatment, and that can limit or restrict your peripheral vision, as well as because of some scarring, it can affect your central vision, and unfortunately, that cannot be reversed. So my advice to all my patients is always don't wait until you reach that stage. Let's try and control and do things before, when you're in the milder stages.
So when do or how do somebody who isn't diabetic right now know that they have to go to you? Like, and what's the process that they would go through to reach somebody like you, like a specialist? Yeah. So do they go to a GP and come to know, or what are the symptoms that they are looking for now?
Well, the early stages of diabetes, they don't have any symptoms. So the patient won't know that they've got a problem until they actually start having a problem with their vision. And in early stages, sometimes you may not have any symptoms at all. So I think the first step is, as soon as you're diagnosed with diabetes, is to see the optometrist and get your eyes checked, because they can do diabetic screening. You can also see the GP and get a referral to see a specialist or an optometrist who can then screen your eyes for diabetes, and we can then pick up the early stages. Once diabetic screening generally is done every 1 to 2 years, depending on which stage of diabetes, diabetic retinopathy the patient has, and that can tell us whether the disease is progressing, whether it's stable, whether we need to treat it, and we can do early treatment. So it's all about early treatment, early diagnosis and treatment. So I think following the correct steps and starting their eye checks with the optometrist is the first step to go ahead.
That's interesting. Like, if I don't wish any of you, but if anyone is in that stage where you are just pre-diabetic or diabetic and you haven't had any vision issue, but you should get yourself checked with someone and get it. Just, it's best to check, right? Why to take risk later? But
of course, absolutely.
I mean, once you are in that path, yes, lifestyle helps you, but you should always know what's happening with your body.
Absolutely. I totally agree. And most of the eye conditions, early diagnosis is the key, so you should get it checked, because some of the eye conditions may not give you any symptoms when they are at early stages, but they are happening in the background. Mm. So,
because that's what happened, Swati, when one of my uncle, he lost his partial vision, and when he went to doctor, said because of your high blood pressure, he lost it. Mm. But that's all we knew. We did not had any idea what to do after that.
Yeah.
Because half of the time we are half educated about these things. Mm-hmm. And I'm so grateful that you have come up over here and you are talking today about all these things, because this half education always led us to delay things.
Correct.
And ultimately we reach at a stage where it becomes very difficult to cure. Yeah. We are only preventing further damage, but we are not able to cure.
Correct. You're right. With conditions like blood pressure, once the event has happened, you can't reverse it. But the necessary steps have to be taken to prevent similar episode in the other eye or similar episode in the rest of your body. So if a patient has had a mini stroke in one eye, he is at a higher risk of having a major stroke, and he needs to see his GP, have optimum control of his blood sugar, blood pressure, and cholesterol, and also may need to be on some blood thinners. So all those things have to be discussed to the GP once the patient has had this problem.
Oh, that's a big thing. So the other major thing that we see always whenever we discuss about eye, and I know this since my childhood too, it's about cataract. But from then to now, the things have changed a lot. I've seen when I was young, I was very young. I remember the grandparents of anyone's family, they'd be wearing these big glasses because they had a cataract operation. And now I see it's just 2 days work to get cured and come back. So throw the light how it has evolved and what kind of thing, different lenses has come up or what kind of surgery has come up. People are still scared. Honestly, when they hear, oh, I got this, they feel their world has died.
Yeah.
So, yeah.
Yeah. Well, cataracts and cataract surgery has come a long way in the last 30, 40 years. So when I trained myself in India, we used to do cataract surgery with a really big incision, almost 10 millimeters. And then there were stitches put in the eye, and the eye took a while to sort of, get back to normal or heal. Now our incision size is 2 millimeters. So we've come a long way. So it's a very tiny wound that we do a surgery from. We use a technique called phacoemulsification, where ultrasound energy is used to sort of break the cataract in tiny pieces, and then we sort of take them out. So cataract basically is the lens in our eye turning cloudy, and it is an age-related change. So this keeps it will happen to everybody if we live longer. And it's in current age, it is a surgery that is most commonly performed, cataract operation. So the surgery itself takes under half an hour, and it is a day procedure, so you don't have to stay in the hospital. You do have to do drops after the operation for up to 4 weeks, but your vision is significantly improved in the first week, and you do notice a lot of difference. Coming to the lenses that we can use for cataract, after cataract surgery. Now, initially when I got trained, there was only one type of lens that we could use. Now there are multiple options, from standard lenses to premium lenses. Most lenses sort of are designed to fix you for distance, so you won't need any glasses for distance. However, there are now lenses that can tackle your intermediate vision, so computer vision, so if you won't need glasses for computer, and there are some lenses that can tackle all three distances, so you won't need glasses for driving, computer, or reading. So that's a great advancement in cataract surgery, because there are so many people that are still working at the age of 60, 70, and they would like to be glasses free, and they would like to be working on their computers and doing things that they like to do without having a hassle of remembering where they kept their glasses and all those things. So these lenses are quite premium, and they are very well designed, and they work really well in most of the population. So I think cataract surgery is something that everybody should consider, because it's as I said, most common operation that we do, and it's not as tedious as it was maybe 25 years ago.
No, that's great. So don't get scared of it. But since we spoke about the old people, now let's speak about the premature babies. What is ROP? I have heard this term a couple of times, retinopathy of premature, but what is it like?
So ROP, retinopathy of prematurity, it is a condition that we see in babies that are born prematurely. So what happens is the blood vessels that grow in our retina are completely grown by term, so by say 40 weeks of pregnancy. But when the baby is born prematurely, the blood vessels haven't grown all the way to the periphery, and when the baby is born prematurely, they need a lot of oxygen to be able to survive, and because of this oxygen imbalance, sometimes the retina can produce abnormal blood vessels, and if those blood vessels are left unnoticed, it can cause detachment of the retina. So that's the end stage of ROP. Again, ROP has stages, and we screen these babies every 1 to 2 weeks once they are born. There is a screening criteria that we follow Australia wide, and we screen the babies every 1 to 2 weeks to see if we can see any changes of ROP. And depending on what changes we see, most babies would just need screening, because eventually as the babies grow, the blood vessels grow with them, and in most cases, all of the retina has normally vascularized. In some cases, though, the retina fails to grow those normal blood vessels, but starts showing signs that it is sort of approaching, stage 3 or advanced stages. And in those cases, we may need to laser the retina or give them some injections in the eye. So we need to treat them. Again, the parents won't know that this is happening because they can't see anything. The eye doesn't get red. The baby is fine, doesn't have any pain. So the screening is extremely important, and I think it is mandatory for all premature babies to go ahead and have those screenings. So I actually started this service in one of the local health networks after I finished my fellowship and came back to Adelaide. So until then, so this network is called Northern Adelaide Local Health Network. And until I came back, those babies were traveling almost 25 to 30 kilometers. And for Adelaide, it's a long way to another hospitals to get screened. Which was a hassle for really tiny, sick babies, because these babies are not always, they've got oxygen, they've got a lot of other health issues because they're little, and it used to cause a lot of problems with the travel. So once I started the service, I think we don't send many babies to these other hospitals, and we try to manage them in our network. And obviously, if they need treatment or something that the network cannot provide, then we have to transfer them. But most babies are managed in.
When you hear premature babies going through this,
Yes.
you feel that, that emotions.
Yes.
And then parents can't know it, and you guys helping them to early detect it, to prevent it, to cure it, and that too you have taken that step to create it within the community.
Yeah.
To help these babies. That's amazing.
Thank you.
That's what feels like a human in doctor. That's because I know doctors cure, but then that human factor in you has made this big change. Squinting. I always wanted to ask this, because squinting brings a lot of bullies too.
Yeah.
Squinting brings a lot of emotional problems too. But there are health challenges also with squinting. I want to discuss that. And also, one of these podcasts which I was listening a couple of days back, somebody said, oh, I used to squint, but now I don't. And he took the glasses out, and with the glasses, you don't know that he's squinting. But when he took the glasses out, it was minor squinting was still there. I could see it. But he was telling his journey of being bullied, his emotions. But then he was also talking a little bit about his physical challenges. And he's a big entrepreneur running billion-dollar business in US, along San Jose to San Francisco, that area. I really want to understand this, because this is so important. There are so many parents also, those who don't know what to do with the kids. They just feel that, oh, he's born like that, like he's just birthed, something like that. But if anything can be done.
Yeah, well, squinting is a really vast topic, and there are multiple reasons why a child can squint. But the most common reason is, again, need for glasses and the child having an uncorrected long-sightedness. So that's the most common scenario. But of course, there are multiple types of squints, where the eyes start to go inwards, where the eyes start to go outwards. Sometimes there could be sudden onset squint, and if there is a sudden onset squint, then that definitely needs to be checked fairly urgently, because it could be something related to the brain. Not always, but sometimes it can be. But it definitely needs a quick and urgent check if you can't get through a specialist, then at least go to the optometrist and get that checked. So that's the first thing that I would like to, get out there. But yeah, as I said, in most cases, squint or turning of the eyes inwards is because of long-sightedness. And as you mentioned, one of your guests had the same problem. So there are squints that, not all squints need surgery. There are some squints that can be treated just with glasses, or they get corrected with glasses. And if that's the case, then that's the treatment. Not all kids grow out of squint, so they might have squint for the rest of their life. But sometimes you can improve their squint with surgery or operation, which we do on the muscles around the eye. So we operate on the muscles, and we sort of weaken them or strengthen them depending on what type of squint it is, to sort of correct the squint. And most of the time patients are happy, and
Anything cosmetology is always happy. I know there are other challenges, but anything cosmetology is always happy. People feel happy.
Yeah.
That.
But if there is a small child like under 4 or under 7 who is having an eye turn which is intermittent, it's not all the time, but it's there, then it definitely needs a check, because they would more than likely need glasses, which can, again, coming back to the topic of lazy eye or amblyopia, there's always some component of amblyopia or lazy eye when the patient is squinting. So that needs to be addressed and treated, as I said, before the age of 7. So.
Such a big topic. It's a topic that everybody always, either you're a bystander or you are the one who is facing. It's a topic that is always discussed.
Yes.
Dry eyes. And Australia has a lot of dry eye problems.
It does, yes. Australia also has a lot of dry climate.
Yeah.
So it's most of the time it's weather related, but I see a lot of dry eye in patients who work on computers almost 8 to 9 hours a day. Of course, there are other conditions that can be associated with dry eyes, but most common dry eye it's called evaporative dry eye, which means that because you're constantly looking at the screen, you don't blink as much. So you're not blinking as much as you should. Normally, our blink rate is around 15 to 20 times in a minute. But when we have dry eye, or when we are working on screen, we blink, sometimes less than 10 times a minute. So obviously, when you're not blinking and lubricating your eyes are getting dry. So I advise all my patients that have dry eyes to take frequent breaks when they're working on screen. So they need to take, every 20 minutes, they need to take a break for 20 seconds. And it's called a 20-20 rule. And that sort of helps replenish your tear film, because as soon as you blink, your tear film sort of forms again, and then you can start working again. Dry eyes also sometimes make your vision go fuzzy, because again, they're very dry and the tear film is not lubricating the surface of your eye. And that can cause intermittent blurring of the vision. So again, if those are the symptoms, you take some rest, restart.
Dry eyes, just like me. 2020, I love that dialogue. 20 minutes of working and 20 seconds of break. That's nothing in compared to the 20 minutes. And like, this is like literally a magic potion you just gave.
Absolutely.
Yeah.
So you just keep your eyes closed for 20 seconds and...
Wow.
Yeah.
I'm going to do it. So I have very big issue of itchiness because of dry, and I constantly keep on itching, and it's also changing my eye shape now.
Yeah, because
they constantly itch, constantly rub. So that's why it's changing the eye shape. That's what last time I heard, that it's changing my eye shape now.
Yeah. Well, the constant rubbing is never good, because it does change the shape of the front of your eye, and sometimes you can have a condition called keratoconus, which sort of exaggerates because of constant rubbing of your eyes. Which means, so keratoconus means that cornea, which is the front part of your eye, or the front window of your eye, is supposed to be round, but then it becomes conical because of constant rubbing. Now, not everybody that rubs their eye gets keratoconus, so it could sometimes be genetic, or constant rubbing, or if you've got any eczema or any condition that causes constant, or allergies, that causes constant rubbing that can lead to keratoconus.
Yeah, but 2020 is something I'm going to do. I sometimes see, Swati, people with red eyes, one side of the eyes is red. Why does that occur? Like, what's that? Bloodshot eyes, they say it. Oh,
So you're talking about surface eye?
yeah.
Yeah, so surface eye is basically formation of a scar tissue. That scar tissue is called pterygium, and it is because of constant ultraviolet light exposure. So if you're not being sun smart and not taking care of your eyes, and wearing good ultraviolet light protective sunglasses, then over a period of time you might develop this scar tissue that sort of grows over from the side of the eye over the cornea, which is the clear part, and that can cause significant redness, irritation, dryness, watery eyes. And the other thing to remember about pterygium is you don't want the pterygium to, because it's a constantly growing process, and it's slow, but it does grow. You don't want the pterygium to grow close to the center of your vision, because if it does grow over the center of your vision, you can't, even if you decide to do an operation and remove that scar tissue, you would have a scar which would which would be right in the center of your vision. So that is too late for a pterygium operation. So if you do have a pterygium, you need to get it checked at least once a year to make sure that it's not growing too fast, and if it does, and if it is approaching the center of your vision, then it is better off removed by an operation.
That was real. Swati, we have discussed now about all these medical conditions, but I also know that you are a very you like to speak. You have been into so many speaking events, and you have done so many events. And recently, you did an event in Adelaide too. Give me some of the events that you have attended as a speaker, and what event you created now.
Yeah, well, the recent event that we conducted was for optometrists in our community. It was an education night for optometrists, and I spoke about multiple, eyelid lesions or cancers around the eye. So I did talk about that, and then we had our fellow, my colleague, Dr. Bauzeli, who spoke about some retinal conditions. So we do conduct these optometry education nights we try to conduct them once or twice a year, and it's a great way to share the knowledge that we have or they have, and just mingle with the like-minded people in the community. Also, it gives us and them a perspective of what sort of patients we are seeing, what complexities we come across, and how they can help. Being the first point of contact for the patient, they can help with certain tests or certain investigations which would help us to then diagnose and treat the patients in a timely manner. So we do try to conduct this optometry education nights every now and then. I have been presenting at multiple conferences. I've had recent presentations done at the RANZCO SA branch meeting. In my fellowship, I have presented at international conferences in Singapore and also in Adelaide, in Australia. So I have been quite active in sort of presenting my work. I am in a process of sort of collecting my data for my next project. So I'm
Interesting.
We'll see how we go with that.
But you just right now told that in this optom night, you touched a bit on cancer regarding the eyes.
Yeah,
right?
yeah.
Because this is very sore subject, and not cancer to the eyes, but cancer is a very sore subject. I lost my dad and my uncle both to the cancer, and it's really still very touchy point for me. But since we're discussing about cancer, about eyes, I know one of my friends' sister had eye cancer, but that's all we heard, right?
Yes.
But what is the cancer that you spoke about?
So I on that night I spoke about cancers around the eye. So basically skin cancers that you have around the eyes or surface of the eye. But there are multiple, the types of cancers that you can have in the rest of the body you can have in your eye. So if there is a strong history of cancers elsewhere, on their, like, for Australia, because of high ultraviolet light exposure and Caucasian population, they are very prone to having skin cancers and multiple type of skin cancers. So I definitely educate my patients that if there is a history of multiple skin cancers which are taken from their face or the rest of the body, they need to, and if they notice a lump around their eyelids, then they need to get that checked. Sometimes these kind of cancers can happen on the surface of the eye. So if the eye is, constantly red, irritated, and not getting better with standard medications, then that needs to get checked, because sometimes it could be a start of cancer. If it is, again, everything comes to early detection. So if we can detect it early, we can treat it effectively without causing significant loss of vision or loss of eye. There are cancers that are in the back of the eye, in the retina, in younger populations, or really tiny, small babies. There is a cancer called retinoblastoma that we see every now and then. And again, I would really like to educate our audience that if when you take a photo of a baby, sometimes you can see the red reflex, or you can see that red spot. If you see the red spot, which is equal on both sides, then that's a good thing. But if you see that there is a white spot and then there is a red spot in the other eye, then that white spot needs to get checked urgently. Yeah, it's called, so that white reflex can be a start of can be because of any problem in the eyes. It could be a cataract, because babies can also have cataracts, but it can be
as serious as cancer.
As serious as cancer. So you definitely, when you're taking photos for babies, or and if you see one red reflex doesn't look the same as the other, even though it may be nothing, you should get it checked.
Just get it checked.
Yeah.
So I was recently listening to, those reels come up, but one of the reels was saying that nowadays the technology have started coming which can detect cancer before it is occurring. Is it going to, is there any news like that it's going to come, or is it coming? Because see, once cancer is there and you're detecting and you're treating is a process. But if something like that can come, that can detect before it is happening, oh my God, that would be a blessing.
That would be great, actually, but I am not aware of any such technology, at least for eyes, so I'm not sure. But yeah, that would be a great option thing to happen.
I don't think these days half of the things come on the reels that they just put. AI gives them and they put it without even realizing. But somewhere I was like, wow, if this really happens, what a blessing.
Yeah, absolutely. Yes, I would be looking forward to that
even
kind
if
of technology.
10% of the population can use it, let's say it's very expensive, half of the population cannot, or 90% population can, even the 10% population that can afford it, still a blessing.
Yeah, but I don't think there is, at least I'm not aware of any evidence, so we don't know whether that information is authentic or not. So I think we have to wait and watch. We'll see if something comes up in science. Science is ever growing, so anything can happen.
Yes. You have got a very beautiful clinic in Adelaide.
So we do, yes.
So tell how many people, how many nurses you have, doctors you have?
Well, we've got 2 doctors, but we've got allied health. So we've got orthoptists. We've got a couple of orthoptists working with us, and also an optometrist working with us. We are I would say we're a small team. We've got under 10 employees, and they've been very supportive. They've been very helpful in setting up the clinic. So we only took over this clinic in 2023. Mm-hmm. Before that, we actually started our own clinic in 2020 in the middle of COVID, but that was a single doctor practice, and it was a smaller practice, and we actually started the practice as a trial. And when I say we, it's me and Ninad, my husband, who jointly sort of wanted to go on an adventure. So we decided to start a practice on our own with no background whatsoever. And we were quite overwhelmed with the response, so we grew really quickly. And in the 2 years, I think that space that we were renting for a clinic was just not enough.
Yeah, you outgrew the space.
Outgrew the space, and we were like, we definitely needed a bigger place. And this offer came up, and we couldn't say no because it was such a good clinic, and I had all the space that I needed. Um, and since then, we've been constantly growing,
Yeah.
and touch wood, we keep
You
growing.
you are doing amazing work, so you will definitely grow. So
Yes.
why Adelaide? Like why Adelaide in all Australia, and what charms you in in that
I
space?
think Adelaide is gives us the balance, gives us the work-life balance. We come from, both me and Ninad, we come from as I said, the busiest city in India, Mumbai, and we've lived it all, we've seen it all, the traffic, the travel, the you know the yes. So we've done it, seen it. And when we came to Adelaide, we started with Adelaide because Ninad did his MBA with University of Adelaide, and we just loved it. We just loved Adelaide. We tried, we visited Melbourne, and then we visited Sydney, and we did give it a thought, but we didn't want to go back to the wasting time in traveling.
I can understand. If you don't know, if you are one of my audience that don't know what is Mumbai, Mumbai's population is more than Australia population, the whole
Yes.
Australia population.
Yeah,
So you can
absolutely.
understand why when Swati says it comes from one of the populated state of a populated city. Mumbai is a city. It's not even state. Yeah.
No, it's not a state. It's a city,
City.
and it's got all the population that Australia has.
But once you're
it
in
is a very
Mumbai,
busy.
you just love Mumbai.
Well, yeah, of course. I mean, once a Mumbaiite, you're always a Mumbaiite, and I love to go back and I love to relive those memories. But we are now, I think, so used to Adelaide life
Yeah.
that Mumbai can be really fast for us sometimes. But yeah, Adelaide, as I said, it does give us a good work-life balance. Even though we both are extremely busy in our lives, at the end of the day, we do come home on time, and we are able to spend some family time, and and I think we're just too settled in Adelaide. We don't want to go anywhere.
And it's amazing that you are here in Sydney for watching the badminton finals.
That's right. That's right. So there is an Australian Badminton Open, which is going to happen over the weekend from tomorrow onwards. And my son is a very avid badminton player, and he's always excited to see these tournaments live. So we are all here for him, and hopefully he gets an autograph from his favorite player. So just fingers crossed.
Yes, and that's the kind of what you do at your home. That giving that environment to your child to grow is what kind of compassion you also bring that to your patient and to your
Absolutely, yes.
to all the kids that comes. And through our discussion I've seen it's not always about treating. You have always told about prevention, you have told about early detection. You could see that passion for patient first.
Yes, absolutely. Well, I think I totally believe in patient-led services. So it all has to be in the best interest of patient. That's my aim, my goal, my passion.
So when we are talking about all these things, I wanted to throw some light on age-related macular degeneration. What is it like? Yeah, some light into it.
Yeah, so this is a very common topic in older population. So sometimes after the age of 60, we can see this condition. So macular degeneration basically means, so just to give you a background, in our retina, there's a central part of the retina which is called macula, and that's the highest functioning part of our eye because it's constantly helping us see and helping us see fine vision, color vision, and also detailed vision. So it is a very, very highly functional part, and when any part of your body is highly functional, it's sort of constantly changing cells. So those cells, they degenerate faster. They produce new cells. They degenerate. So it is basically degeneration. As we grow older, that's why it's seen in older populations. So as we grow older, these cells, they lose their capacity or slow down in their capacity to sort of regenerate these new cells or form the new cells. And whatever cells are getting degenerated are not getting cleared out of the retina as quickly as they would when we are younger. So that debris just sits there under the retina, and that's basically the start of macular degeneration. And that's when we start seeing these changes in the retina, which are early changes. And there are two types of macular degeneration. One of them is a dry form, which is a slow process where this retina is slowly building up with the debris and slowly losing its capacity to see clear, and basically those cells are slowly dying. So what happens in the end stage dry macular degeneration is the patient would lose their central vision, so they would have a central blind spot. They would still have their peripheral vision and still be able to see objects which are larger, but they would lose their fine vision. Sometimes even driving vision is lost if in end stage. Now there is another form of macular degeneration which is called a wet form of macular degeneration. And what happens in that form is, because the retina is slowly dying, in order to survive, it's a normal body response, this retina or this macula will start producing abnormal blood vessels in the hope that to survive or to give that oxygen or nutrients. But those abnormal blood vessels are abnormal, and they are very fragile. So they can leak, they can bleed, they can cause swelling in the retina or the macula, and that can cause profound vision loss. So you can have a sudden, one day you wake up and you can't see anything out of that eye, or you just lose your central vision, or you have a central blind spot. And that can be treated by giving injections in the eye. The injections in the eye, the concept sounds very, very daunting, but it's not. They are very routinely performed, and it's not as bad as it sounds, and you don't feel much. But those treatments are important to sort of restore your vision and stabilize your vision to where you're at. And in the process of doing that, in most cases, you do find that the vision does improve eventually. But that's not the aim of the treatment. The aim of the treatment is to stabilize your vision so you don't get any worse. That's macular degeneration in a nutshell. But it's very important that if any patient has any distortion in their vision or any central blind spot, or if they have sudden change in their vision, is to get them checked. Again, the first point of contact can be an optometrist or a GP, and then they can be referred to us for further treatment.
That's so scary. You wake up one day and you cannot see. It just scared me. Oh my God.
Early detection is the key.
But how do you keep your mental health? Like, you see so many things all around, and it affects a lot, right?
Yes.
And how do you detox yourself, Ninad?
Well, I do try to have frequent breaks. So only recently we went on a girls' trip over the weekend, and just don't talk ophthalmology at all, and just be with friends who are not doctors, and it's just easier that way. But yeah, I have learned to switch off as soon as I come home. So I generally don't work from home. I don't do any sort of I don't generally do, unless it's very urgent. I generally don't do anything that is work related from home. I try to spend more time with my family. There are some cases that do disturb me, and I'm sometimes worried about them, and I do follow them up very closely. But yeah, I do try my best to sort of switch off and do my own things.
Yeah, so your family and your friends help you
and
around.
Absolutely, and I like drawing, and I like painting, and I like cooking. So I do a lot of cooking. And cooking is like therapy for me.
Maybe next time when I'm there, invite me for a food.
You should come and you should stay with us, and we'll have a feast.
Definitely.
Recently, and now I'm learning to bake. I'm learning to bake a bread, a sourdough bread. So that's my new project.
Oh, wow.
So I keep doing something.
It was wonderful chatting with you. Thank you for coming to my show, and we had lovely time and a lot of education. I know there was a lot of education in it, but it was really great. It was eye-opener.
Yeah, thank you so much, Alka, for inviting me and finding this time to do this in such a tight schedule. But I'm glad I'm here, and I'm glad I spoke to you. Thank you so much.